Yeah.
We've now gone live.
Okay. So welcome everybody to the first Health and Adult Social Care Scrutiny meeting since the shutdown, or actually since before the shutdown, because the last meeting was scheduled for the Monday before the shutdown and it was postponed because of that. So it's been 6 months since we've had a formal meeting. We have had informal meetings on Zoom or Teams or whatever it is, and very useful as well. So this is our first formal meeting, and it's really a catch up for members of the committee because, as most people will know, the world has changed in those last 3 months. So we need to know, we need health partners to tell us what these changes are. And as anybody familiar with the way that Scrutiny, Health and Adult Social Care Scrutiny has evolved to work, most of our work is done in between the meetings, in informal meetings, and we use the formal meetings as a means of marking where we've got to, and of making any significant statements, etc. So just a welcome to Councillor Hollis, first time on our team, Richard. And I think we got Kirk from the Health Authority. I don't know whether Kirk's been. Have we got anybody else new, Paul?
Yeah, don't have Kirk there at the moment yet. So did you just want to introduce your members of the committee?
Right, so our members of the committee is Brian Tyndall. Brian, can you just give a wave when we say or salute or something? Brian. Richard Hollis. Richard, yeah, well done. John Howe. John, just give a Michael Lilly and George Cameron.
Present, Chairman.
Thank you very much. Okay, is Chris Orkin with us from Healthwatch? No, okay. Well, we're due to have Chris Orkin from Healthwatch, but it might be Joanna. Can I just a bit of housekeeping first? Can I ask people to ensure that that we're not going to get any noise distractions, so phones switched off, etc. And to allow for a slight pause between items and questions. If you want to ask a question, then there's a means of doing so. What's that means, Paul?
Either use the chat bar or they'll just wave.
Either use the chat bar or wave, and one of the officers will pick that up and field your question. It might be just as well to say who you are and who you represent when you ask the question or give an answer indeed. And please only speak when you're asked to do so, as it can descend into a bit of a incomprehensible mess otherwise. But I'm sure everybody here is far more used to using Teams than I am, because that seems to be the mode now. Okay, so declarations, itemised minutes. Can we have, who was at the last meeting 6 months ago that can propose the minutes? So George is going to propose it. Can we have a second? Brian's going to
second it.
Thank you, and Michael wants to as well, so that's fine. Oh, there. Thank you. Right, minutes signed. Right, now we go to declarations of interest. Have any of the committee members got any declarations of interest to make? Just shake your head if you say no. No, Brian, you haven't?
I think I need to note that I'm chair of audit because just one of the strategic risks is the pandemic, which would you believe covers COVID-19?
Okay, Brian, noted. Right, we haven't received any written questions from the public, so there's no public questions. So we move now on to item 1, first item on the agenda, which is item 4 actually.
Yeah.
Adult Social Care Annual Statutory Complaints Report. Now I do believe that we've got Dr. Tozer.
Certainly have, and you've also, Chair, got Helen Babington.
Oh, thank you.
A couple of words.
So if you like to lead on this, please, Carol.
That's absolutely fine, and I'll bring Helen in. And Helen, thank you very much for joining us this evening. So delighted to bring this report to committee tonight. Contains some important key messages. The first one I would ask you to note is that in the year ending the 31st of March, we received 184 compliments versus 75 complaints. So bearing in mind that people will let you know when things go wrong, but sometimes they don't always have the time when things go right, and indeed people have I think an expectation that things should go right or when receiving a public service. But nevertheless, I'm very pleased to note that. Of key importance is the learning from complaints. I'm going to ask Helen to take you through that. But the one issue that I do just want to say finally by way of prologue is that we did have one fault found by the local government social care ombudsman. And again, that's significant for me because that is somebody's last right of appeal. You complain, your complaint is investigated, and a decision is made. You then have a right to an appeal, and we'll look at it again. But actually, if you've exhausted all local opportunities, then the ombudsman is your last course, your last resource and recourse to have your concerns raised. So there is one issue there, and I will ask Helen to please just take us through the report in detail.
Hello everyone. I think as Carol's just introduced, it's important to note the context of the compliments received in respect to the number of complaints that are received and appeals. The number of complaints and appeals is quite stable from year on year. Certainly the last three years figures are quite stable. In terms of the LGO case that Carol, the local government ombudsman case that Carol's referred to, there was a finding of fault. With any finding of fault, whether that's in our local process, our local statutory process, or when it's found fault by the ombudsman, we certainly seek to adopt a lessons learned approach from that. And I think Carol again referred to the learning from complaints that we hold great store by in the service. We report quarterly to Service Board on all the learning from complaints identified in the previous quarter. A really important part of our formal statutory process is the completion of a close down and learning form at the end of that investigation. We seek to fix matters upstream wherever we can, and that's certainly an approach that the local ombudsman endorse. They want to see that evidence at local level of when somebody does raise concerns, the lessons learned approach. And certainly the completion of the close down form and the reflection by the investigating manager at that point in time is really helpful to feed that learning and those practice improvements in the service. The learning from complaints can vary. I mean, we even seek to learn from complaints if we've not upheld a complaint, because it's about understanding how that complaint came to be made in the first place. So even when we've not upheld a complaint, it's important that we really look at how that complaint's been made and the circumstances and see if we can learn anything from that. Whether the communication could have been better, an improvement to a form, something that we would seek to improve for next time. So the learning from complaints varies. It can be something, as I say, quite simple, but sometimes more wider practice improvements need to take place. And certainly a lot of the quality and audit work that's happening in service and being driven by the practice development and the principal social worker is looking at quality and audit to strengthen that practice. Does anybody have any questions about the report? Anything I can clarify for anyone?
Richard. Councillor Hollis.
Yeah, just a sort of question. I mean, we've got the figures in the report. How does that compare with, if one can compare with other authorities? Are we ahead of the game, or are we sort of, is it average, or how does that compare?
Thanks, Richard.
Thank you, Councillor Hollis. This is a question that comes up regularly, and it's certainly something that we discuss. I'm part of the Southern Region Complaints Managers Group, and it's certainly something that we discuss in between authorities, because I think everyone is keen to know whether they're an outlier and to know whether you're doing something that you should be doing or other authorities are doing something wildly different. I would say when we have this discussion at Southern Region Group, we always come back to the same issue, that it's very difficult in some ways to benchmark complaints against other authorities, because every complaint is so very individual and circumstances are very individual. So it's very difficult in some ways to benchmark. However, I think what we can benchmark against, and certainly I've had an inquiry recently from, I think it was Kent. They were looking at their performance indicators in terms of their complaint handling. So whilst it's very difficult to compare complaint to complaint because they're all so different, what you can look at is your complaint handling process and your timeliness. We are certainly well within our 25 working days to complete a complaint investigation and provide a written response. I think the figure in the report is 18.83 days. So we are certainly well within our statutory timeframe of 25 days. And that is, again, well within statutory guidance, which actually says you've got up to 6 months to resolve a complaint or to respond to a complaint. So I'd be quite happy. I'm quite happy with our timeliness, and I think that bears well against other authorities. Certainly, some of the responses that came back to Kent's question from the group were figures around 50 and 60% of complaints, only 50 or 60% dealt with within statutory timeframe. So we are 100% and we are well within that 25 days. So I would be confident in our complaint handling process.
Carol, did you want to come in on this? And I've got Brian.
Yes, thank you very much indeed, Chair. I think there are two things to add to what Helen's just said, Councillor Hollis. The first is that on an average day, this department, adult social care, is working with 3,064 people. That's generally the numbers of people that we're working with on a daily basis. So I think complaints need to be put into the context of that. Secondly, I don't think I want people to complain. No public service is ever perfect, and actually we need to ensure that people understand not only their right but how to make their complaints, and then we have a duty to demonstrate how we've listened and learned from that. So I think, you know, I think the question about benchmarking is the correct one, and why we've included in the report the last 3 years is so you can see that it's relatively stable. Now, if we think about the context in which adult social care has been operating over the last 3 years, we have, and I'll talk about this a bit later in my presentation, but you know, we've had to be making some incredibly difficult decisions. We've been having to go out and review people more and more and more, and to be absolutely certain that what we are delivering, of course, meets our legislative, our statutory duties, but it doesn't do more than that, because actually we don't have the resources to. So what I would suggest, that even though we've had and we've needed to make some very significant savings in adult social care, but that not to have been accompanied by an increase in complaints. It's not a perfect correlation, it's not proof positive, but it's an indication that the way in which we're operating, by and large, is meeting with people's, approval. But we need to ensure that people know how to complain, and no complaints does not equal brilliant performance, because actually I'd be asking myself the question more, is that because people don't know how to be able to get their voices heard?
Thank you, Carol. So we've got Brian, Michael and John. So Brian.
Okay, a couple. First of all, page B9, paragraph 54, about feedback, National Social Services ASC Survey England. It says it's been embargoed at present. Can you just tell me why that is?
Carol, Ellen?
Oh, I think from last year, we were in the same position last year. Those results of the survey are reported through a separate scrutiny. So the business information team although they may have some of those results, they are reported through scrutiny through a different route. I don't know. Can Carol correct me?
Yeah, I can come in. So this is a national survey which we administer locally, but goes back as part of a statutory return to government. We don't get and those returns go, so our business intelligence team send out the surveys for people to complete. They're returned nationally, and they go in nationally, and the decision to around the date of publication is it comes out as a government report, and the decision is that of government as to when, and it's embargoed by government until that happens.
John, second question is,
Thank you.
I think Helen or Carol said there's been one appeal where we were at fault, if I heard it correctly. If so, what was the fault? What was our fault?
I will ask Helen to come in here.
Okay, thank you, Councillor Tyndall. There was it was a complaint that went to the local government ombudsman, and they found a fault with the council, a failure to fully implement. The fault found was a failure to fully implement a care and support plan, and also carer support for the son of a lady who lived on the island. It was a very, very complex case, and they lived here for a number of years. There was incredibly difficult communication difficulties between the social worker and the son concerned. However, although the Ombudsman acknowledged those communication difficulties, however, the council was held to higher account. So while they acknowledged those communication difficulties contributed to the difficulties the council had in implementing the care and support, as a public body, the council is held to higher account, and therefore they found fault.
Okay, and just one other thing. Obviously, yes, this report goes up to March. Have you actually found the complaint level is going up? I know you're not, well, you are recording it, but is COVID making any difference to that at all? Anything noticeable? That's all. Otherwise, I've finished.
In terms of COVID, it's been an interesting reaction with complaints. At the very beginning, there was a huge amount of goodwill and patience, and I think there was a real message out there that everybody was in this together, and I think making complaints was the last thing on anyone's mind. We've obviously, as we've got into the period, like we all know, it's become the new normal, and a lot of that goodwill and patience is, I'm beginning to see evidence that that's eroding, and the complaint level is rising from what it was at the beginning of COVID, but it's actually not standout. There's not a standout increase from this usual time of year. It's always very difficult to predict levels of complaint, but I have to say I've not seen anything as a direct result of the COVID situation coming through the door, which I think at one point we were concerned might happen or could happen, but I've not as yet seen any direct increase because of COVID.
Okay, thank you very much.
Thank you.
Thank you for that, and thanks for the reply there, Helen. Michael, it's your turn.
Thank you. I've got two questions. One relates to, I think, section 43 on B7, which is about, it says here, whilst family members are often effective advocates, at times it is helpful to provide independent trained advocates to assist with complaint issues. I'd like to dig deeper a little bit to know more about that, because I come across many people in my ward who actually find it very difficult to necessarily advocate their needs and case, if particularly often the carers for the family member. How do people get hold of this independent advice, and how do you sort of make the decision that is needed?
Thanks,
I'll come
Michael.
on to my second question in a minute.
Thanks, Michael. Who's going to respond to that?
Do you want me to do that?
Sorry, Carol.
Helen, do you want to do that?
Yes, yeah, that's absolutely fine. Thanks, Councillor Lilly. Quite often, as I say, and I think the majority of where an advocate is involved in making a complaint on someone's behalf, it is an informal advocate. It's a member of the family. It's sometimes a friend or other support. And we would always look to obviously seek the person's consent, that they are happy for that person to advocate on their behalf. Sometimes an informal advocate becomes complicated when that person is actually involved in the matter complained of, because you've got to be very careful that they are acting for the person and you're hearing the person's voice. I would always work really closely with the social worker, because the social worker would always have a deeper relationship with that person and a deeper understanding of the circumstances. So I don't ever make a decision about an advocate in isolation. It's an informed decision working with the social worker and the person to determine how they want to move that forward. Sometimes it is better to appoint an independent formal advocate. Like I say, especially when the informal advocate could be involved in the matters complained of, or it could have an implication, an outcome could have an implication for them, because you've got to be concerned about conflict of interest. We commission a Southern Advocacy Service to provide formal advocacy, and we've had some complaints represented by a formal advocate. They don't purely do complaints advocacy, so they wouldn't just advocate for somebody to make a complaint. But if it is in connection with a Care Act statutory duty, they provide Care Act advocacy, so they would support the person about that substantive issue. And we work closely with the Southern Advocacy Service advocates. I don't know whether Carol wants to add anything about our commission with advocacy.
Thank you, Councillor Lilly. So just to add to what Helen's just said, I'm very clear in terms of what I expect social workers to do. So, for instance, if the complainant is say a 90-year-old individual, and their husband, their wife, their partner is equally aged, and has maybe some issues of their own, which may undermine their ability to be able to advocate really clearly on behalf of their spouse. I'm very clear as social workers, they should be, if a person needs advocacy, who is best placed to be able to articulate those issues. And sometimes if you're ill yourself, or you have needs yourself, you might not be physically able to do so. So that's another reason. Helen's mentioned conflict of interest. That's another reason why you would ensure that you want somebody to be able to be a strong voice for the person. And sometimes that's not always your nearest and dearest. Equally, you may have a son or a daughter and they may be hundreds of miles away and physically unable to participate in meetings or whatever. So there are a whole variety of really best practice reasons why independent advocates can be massively helpful. The independent contract with Southern Advocacy, recently we've gone through a recommissioning of that, and Laura Godian and her team have led that piece of work, and I'm pleased to say that despite our funding difficulties, we have managed to put some additional resources to that independent advocacy because it is so important to people.
Thank you, Carol.
Could I please add something that I'm just thinking about?
Go on, Helen.
Thank you. When Carol mentioned about making sure that that person's voice is heard and they've got and that's made possible, I think it's worth noting that yes, we have a statutory complaints process. Yes, it's a formal process, but within that formal process, we absolutely have room to adopt a different approach if needed, and every complaint, every case is looked at on individual circumstances. Sometimes, you know, Carol mentioned the example of somebody quite elderly. They may want a face-to-face meeting straight away. They may want to bypass the formal process. We can be very, very flexible in how we approach those circumstances, because my role is to make sure that that the approach we take is appropriate for that person. So it's not always about shoehorning someone in a formal process if we can achieve a better outcome for them without that.
Helen, whilst we're responding to Michael's question, I did have a phone call this morning from a regular caller actually, expressing concern at not being able to raise concerns through his social worker about information accessibility, because he claims to have been told on three separate occasions that the only way he can make a complaint is by email, and he doesn't have email. Maybe that's something that could be taken up outside of the meeting.
Absolutely. Would you be able to email me those details outside of the meeting?
Yeah, sure.
Sure. And then I can look into that. Absolutely.
Sorry, Michael, but you raised a relevant
and that is utterly incorrect. So as Helen will do, but thank you for raising it, and we need to sort it.
Michael.
Thank you for that. I think it's before I go on to my second question, obviously we're now under COVID, and as you said, you know, you talked about face-to-face and things. A lot of this is now very difficult. We do know that I know obviously of a case where you've actually got the next of kin are actually in lockdown in the mainland, in fact one in another country, right, and are trying to sort of communicate in a real impossible kind of way through telephone, through online, within that. So the complaints procedure is obviously going to get more complex, simply because people can't have that same kind of access. Often if they've actually been discharged into a home, they don't even know when they're actually going to be able to physically see their loved one. within that. I just wanted to know, sort of supplementary to that question, and I'll go on to my second question. How are you looking at modifying the complaints procedure to take on this wonderful, well, not the reality of COVID, that has made it very complex for people to have the kind of dialogue they would have had before?
I think that's it's a really good point, and it's certainly something that we're looking at as a Southern Region group. Again, sharing best practice is really important among our Southern Region group. Lots of people, we're looking at it at the moment, and lots of people have got some ideas, some of which will work for some people, not for others, but we're looking to draw together some guidance because we're all basically in the same situation, and we've got to start and look at how we can be a little bit more creative in certain areas, and about, like as you say, about accessibility, and the people we deal with, we cannot always assume they've all got online access and are computer savvy, so we need to be creative. But we're pulling together some best practice guidance from certainly across our Southern Region complaints manager group, and we will be updating our complaints policy and process once we've worked through that.
Thank you, Helen.
Thank you.
Sorry, Michael. Will that stretch to other departments within the council and across other health partners? That's a really important question, Michael.
So there's a statutory complaints process for adult social care, which is separate from the council's complaints department, and which is separate again from that which is run within the NHS. If only life were easy, Chair.
Okay. Yeah, thank you, Carol. Sorry, Michael.
My last question again is, what about the people who don't feel that they can complain? It takes a lot of actual courage for people to stand up and actually complain. We are a nation, and I think particularly on the island, where we feel very uncomfortable to make complaint, and probably even more uncomfortable at this time, because we know how much the NHS, the social workers, people involved are putting their own lives on the table for us. So it's actually, how do we educate or communicate to our community that it is all right to complain, and for them not to feel comfortable about that? We do have the usual suspects on complaints, but there's a lot of people who should actually be encouraged, have got genuine reasons to complain, but often actually shy away from it. I just wanted to know your response to that.
Very good point.
I'm happy to come in and then ask Helen to add, if I may. So number one, we do need to ensure that there's good information out there, that people know how to complain in the first place. Number two, if you're uncomfortable yourself, then it is about talking to a friend, a family, a neighbour, a counsellor, in terms of the role. And I just wanted to make this point at some juncture during this, that actually the role that our counsellors play here is really key, because I think Councillor Lily's point is what we have to have is an array of different ways by which issues, and some of those will become complaints, some of them will just be issues, are dealt with. So information is key. I think that what we need to ensure with how we do is that the social workers, the social care officers, those people who meet with the people, their training is very much around, you listen to the person, you respect the person. You might not be able to give back the answer that the person is hoping of you, but you explain yourself. And your duty to the people you serve is set out in the Code of Practice by Social Work England, about how you treat people with dignity, with respect, with transparency, and with fairness. And if you get those four things right, which are writ large in the Code of Practice by Social Work England, then by and large, most people are very reasonable. You might have to deliver a response that they're not happy with, but that actually they can understand the process that you've gone through. So for me, some of it also, Councillor Lilly, comes back to the fundamental training and ongoing training of our frontline colleagues with how they go about and do their piece of work. And I just repeat what I said about 10 minutes ago. On average, we're working with 3,064 people every single day on this island through adult social care. And we need, and I've also said to you, no complaints is as bad as too many complaints, because it makes, it's clear that actually somehow you're doing precisely, Councillor Lilly, what you're suggesting, which is people don't know, or somehow people feel unable to make their voices heard. If you get social work practice right against those 4 things that I've just said, then actually most people are entirely reasonable. So for me, it's about the training, the quality, the skills, the values, the practice that our frontline colleagues have. And when we look at complaints, the modal reason for complaints is the way in which they've been communicated with. So it will be that actually people haven't taken the time to really explain the conclusions that they've come to when they've undertaken, for instance, an assessment or a review.
Thank you.
Thank you,
Carol. Thank you, Michael.
Can I just pick up where Carol left off and just add something to that? I think if I pick up where Carol's left off talking about social work practice, complaint can be seen as such an adversary word, and in some ways it's about rebadging that word. Someone raising concerns, someone wanting to talk about their experience, all of that is feedback. It's good feedback for the service. We want to feedback. We can learn what we've done right. We can learn when maybe things could have gone better. But if you rebadge something as feedback rather than always a complaint, it's a less adversary term. And that's certainly the way that, as Carol's just talked about social work practice, it's certainly the way I talk to social work practice about complaints, and I talk to social work practice regularly about complaints. They're not a bad thing. I think there's an initial reaction from workers to be defensive, and defensive practice is not something we want to encourage. They should be looking to encourage feedback and looking to encourage hearing about people's experiences. So a lot of the work I do with practice is talking about rebadging things as feedback. We've created a feedback form which social workers are encouraged to take out with them at the point of their assessment. Feedback, as I've just said, can be good, it can be neutral, it can be bad. But sometimes, as Councillor Lilly's made a really important point, some people find it really difficult. They quite often will start and say, I don't want to make a complaint, but I just want to tell you about my experience. And that may be something then we can tease out with them and unpick with them and maybe deal with through the formal complaint process. But it's about somebody having that confidence and putting someone in the best place that they feel able to speak up. The feedback form, since we developed that, has been really useful, because as you made a really good point, sometimes people will be happy to fill out a feedback form, but if you'd given them a complaint form, they wouldn't do it, but they're quite happy to fill out a feedback form. So we've had some really good feedback forms completed. Some have been compliments, some have been complaints, some have been neutral, but it's really important to hear people's experience.
Took the words out of my mouth, Helen. I support that.
Yes, that's been a real positive step.
John, we're on to John now. Councillor Howe. And then Joanna. John, turn your microphone on.
Yeah, I've got my microphone on.
Yeah, that's all right.
That's fine. That's what I remember. That's fine. Thank you. Bye. Yeah.
Right. I want to talk about actual complaints, if I can. That I want to know how quickly you can deal with a complaint. In fact, if it is something that needs to be dealt with immediately, are you able to do that? Secondly,
we noticed that, I don't know on the island how it's worked out, but I noticed that on the mainland, there's been a lot of cases where people have been moved out of the hospital system straight into care homes, and that's brought a lot of the problems with the being caught in the different stuff without. Sorry, I'm getting a bit muddly here, but
we know what you mean, John.
Yeah, they tend to people are complaining it's been a lot of deaths because they've been moved out with the virus and not actually been checked before they've been moved into care homes. So do you get many complaints about that? Thank you very much. Yeah.
Thanks, John. Helen, Carol?
Are you happy for me to respond, Carol?
Because you'll know if you've had any specific complaints.
Yeah, well, on the second point, Councillor Howe, no, we've had no complaints as yet, and I'll caveat that with as yet. We've had no complaints as yet about hospital discharge into care home. So that's quite a straightforward response to that, and obviously I'm not saying that we may not have any concerns raised, but we haven't at the moment. In terms of your first question, how quickly can we respond, and could it be immediate? I suppose in short the answer is yes, and it goes back to, I'll just refer back to a question, to a point I made earlier. We have a very flexible approach to the complaints process. So if it is something, our complaints policy says, if we aim to put things right as quickly as possible for you. If it's a straightforward issue for someone, absolutely, we would look to put that right for someone as soon as possible. And if that means that I refer it straight to social work practice and it's the complaint is somebody hasn't returned my call and I've rung 4 times, absolutely put it right straight away. That assessment, I suppose, is mine when I receive the complaint. Can we put this right for someone? What are they asking? Is it straightforward, and can we do it as quickly as possible? Sometimes it's obviously beneficial if we can put things. It's beneficial in 2 ways: for the person, because they get the outcome they want and they get a solution straight away, and it also is then saving time of the formal process. In terms of manager time, investigating and responding to that. So I think I make mention in the report of how many cases didn't proceed into formal process and were resolved early by the service. So it's absolutely an approach that we would be looking to adopt wherever we can and put things right for people as soon as possible. Equally, where more complex issues are raised or it merits a formal investigation, and the person is entitled to have a formal investigation and a formal written response. So it's very much on a case-by-case basis. But in short, the answer to your question is, if we can look to put something right for somebody.
Appropriately, Helen, that's what you're trying to say.
Absolutely, yeah.
Jolly good, thank you for that. Right, Joanna, do you want to turn your camera on when you're talking, Joanna? As a committee member, it doesn't matter if you can't.
Yeah, will do. Hopefully I'm here now.
At least turn your microphone on.
Yeah, is it on?
Yeah, there we are. Well done.
Wonderful. Took me a while, but I'm on. So I just wanted to say, kind of going over what Helen's just said, that it's really great that over 42% of cases had early resolution. So that's a really good statistic, and it's great that things can get resolved without people having to go through the formal process of the complaints procedure. But I just wanted to ask, with regards to the complaints that are not upheld, is there any learning from those? Because there's obviously a reason that people are complaining in the first place, so there must be something that they're unhappy with. And just because their case isn't upheld doesn't mean to say that they're not, still unhappy. So I wondered whether there was learning from those as well.
Good.
Thanks,
Helen, Carol?
Are you happy, Carol, for me to respond?
Yeah, whoever.
Yeah. Thanks, Joanna. It's a really important point, and I think one I mentioned maybe earlier before you joined the meeting, when we were talking about learning, we expect a close down and learning form to be completed at the end of every complaint investigation and response, even when a complaint is not upheld, because as you quite rightly say, and really importantly, why did that person feel the need to complain? Even if following the investigation, we found that that's not, the substantive matter is not upheld, there will usually be some sort of learning or reflection on that situation to try and understand how that complaint came to be made. So that's why we expect a close down and learning form to be completed regardless, not just where fault is found.
Could that be mentioned in the next report, perhaps? Because that's a good point.
Absolutely, we could expand on that in the learning section.
Only needs a paragraph.
Yes. Yeah.
Thank you for that. Okay, so Michael, do you want to make a proposal?
So I wanted just a point, and then I wish to propose we accept note the report. That's the recommendation. The particular point was I wish to actually thank the adult social care team, because I have had a number of cases, and I know of other people
whose end is that? I think Michael's frozen.
Particularly recently with things, and actually, so I wish to thank them on that. I propose that we note the report. Are you still there?
Yeah, we can hear you, Michael. You're very disjointed. We've got the point. So okay, does somebody want to second that?
Yeah.
All right. George has seconded it. Beat Richard to the, and then crikey, we're all seconding it now. So if we can all vote. Sorry, somebody wanted to speak.
Could I just say quickly?
Yeah, George, you haven't said a word.
Carol mentioned a few times about training, and I think the staff is apart from experience as well, but training is as good as the staff is as good as the training they get, and I think it's very important that these messages are come across at their training sessions, and also the compliments, because that raises their spirits and their morale as well. Thank you.
Good, thank you. So I've been advised sorry, Carol.
I just wanted to come in with two things. The first is just about advocacy. I don't think I was clear. I just want you to be absolutely clear. We haven't let the new contract. It goes out in the summer, but we are adding significant additional funding to it. Okay, so that was the point. I might have erroneously given you. I was just thinking, oh crikey, you made it sound as if it's already been let. The commissioning process is going through. So I just want to be clear about that. And then secondly, it's just to say that I want to formally acknowledge the role that Helen plays. She is an extraordinarily experienced officer, but most importantly, her values and determination and tenacity to ensure that the people we serve are heard through this process. There are others. I have been so impressed with since I've arrived on this island, and I just wish to formalise that to this committee.
Well, I think, Carol, she's demonstrated that in her responses today, so particularly about reframing complaints. In fact, let's abolish complaints and just change them to feedback. So we're going to go to the vote then. So I think the way to do it is if I ask each person and they say yes or no, so yes being we agree with Michael's proposal, and no being we don't. So if I say to George has already has seconded it. I believe you seconded it, George.
Yes, Chairman.
So Brian, yes or no?
Yes.
In favour. Richard?
Yes.
John?
Yes.
And Joanna? Oh, she's not voting. Oh, I'll vote for you. Yes. Right. So that's carried. Thank you very much.
You haven't asked me.
Oh,
yes.
Michael, you proposed it. Sorry, I just assumed you'd be voting yes. Yeah, good. Well, thank you very much. Now we have got scheduled a break for. Oh, that's sorry. That's later on. Okay. Oh yes, so it is. So now we go on to the next item, item 5. Isle of Wight NHS Trust. Now, Maggie, I think Kirk is. Oh, sorry, I'm just skipping over this. Oh, so it is. Yes. So, right, we're on to public health. Question 3. Oh, yeah, agenda item 3. Public health. Members of the public are invited to submit. No, hang on a minute. Where am I? I've lost it, Paul. I've totally lost the thread. Oh yes, there we are. Public health. Oh, Simon, yes, of course, is to provide an update. Simon, are you there?
Can you see me?
Yeah, welcome, Simon. Simon, would you like to tell us what's happened in your world, please?
Many thanks, Chair. So yes, this coronavirus pandemic was first discovered in China in December the 19th. Since then, I've been working hard throughout all stages of the pandemic to prevent the spread of infection and manage that at a local level to protect the island's residents from the infection. So I thought it'd be useful if I just go through some of the kind of where we've got to in terms of the pandemic and a little bit about what we've been doing, and then a little bit about public health services, if that's okay. So we know there's been a steady rise of cases and deaths in the Isle of Wight, lower than the national average, but actually in line with that pandemic curve. And the first peak was managed very well with social distancing, effective planning, and really good partnership working with the NHS. So we've done a lot of work there. But we do know that lack of immunity meant it spread easily, so we had to manage the spread of infection, which is why we had the contain phase, where we were tracking those people coming back from abroad, and then we moved into the delay phase and the kind of national lockdown. And this was really key for us to slow the spread of infection and to have social distancing to protect the most vulnerable and to ensure that the NHS was able to cope and we were able to save lives. So that's where we moved from, and we've kind of over the last few months eased our lockdown kind of measures nationally, and that's been really positive and really good because we want the economy to get going and people to move out the way, move kind of further forward. Sorry, is it childcare issue there? So yeah, if I just kind of stay where we are now, and then I'll say a little bit more what we've done. So as of today's date, there have been 422 cases of COVID-19 on the Isle of Wight, and that's a rate of 298.2 per 100,000. If I just give a little bit of context, Leicester, which you've heard a lot about, has a rate of 1,217 per 100,000, so nearly 1,000 more. And then Lincoln, who's got the lowest rate, is 129 per 100,000. So you can see where we are there. And in the last 7 days, we've had 1 new case. So that's really, really positive and doing a lot of work there. What we've been doing throughout the pandemic is a number of things. I've been the deputy chair of the LRF, the Hampshire Isle of Wight LRF, which is the emergency planning forum where we have worked with partners to prevent the spread of infection and manage that and look at the emergency. There's been a modelling cell which my team's been part of to really understand how this infection is spreading, where it's going, to prepare for any impact, looking at the first wave and then any subsequent cases going forward into the autumn. I've also been chairing a group called Preventing Spread of Infection, looking at our comms, looking at our testing regime, which has been incredibly challenging due to the way it's been set up, and looking at how we support the guidance delivery for our communities, our staff, and anybody else that needs that. With regard to the data, I've been on a daily basis looking at the number of cases, the number of hospitalisations, and the number of deaths to see if we can understand where the pandemic is and how it's travelling and the curve we're on. And I do that on a daily basis. Finally, with regards to the pandemic, I, in line with every other upper tier authority, have written the local outbreak control plan, which was announced on May the 22nd, which covers a number of areas to help us manage this locally. The areas that this covers includes care homes and schools. Now, care homes are very well ably managed under Carol's leadership, and we're just supporting that process, ensuring that we can get the right kind of testing to the people at the right time. Schools, as they've opened up fully, well, more fully, we are ensuring that those schools are open and able to be COVID safe, but also if they need testing because there is a case of coronavirus, we will be delivering testing to those schools or those pupils in that bubble. High risk settings are key for management of the outbreak, so we're looking at how we can support any high risk settings where coronavirus may be more likely to spread or where there's some more vulnerable people. We've done a lot of work on that with environmental health. These settings, as it were, are supported by a number of programs such as testing. So we're now having more leadership of the testing program locally to be able to deliver that. And just speaking to someone this afternoon about all the range of tests and testing opportunities and how we make sure that should we need to implement testing more on the island, we have a good testing program, we can do that. And the TRACE program, you've heard about the NHS Test and Trace. So working locally with Public Health England and the Test and Trace program to ensure anybody who's in contact with a case can be identified and then be asked to isolate. And that links to another part of the program, that of vulnerable people. Again, under Carol's leadership, we have a strong program to support vulnerable people who are shielding. We are now expanding that out or kind of amending it so that it's much more about those who need support because they're isolating rather than because they're shielding because we're in a different place, and we're working closely with that team. And surrounding all of that is a strong governance process with a health protection board that I chair on a weekly basis and a local outbreak engagement board chaired by the leader of the council. So there's a number of things around coronavirus there. I'd also like to say, obviously, I oversee a number of public health services, slightly aside to the actual coronavirus pandemic, and they all have adapted incredibly well to the lockdown, taking a lot of digital interventions, telephone calls and social distancing where they need to do face-to-face work. They're all now standing up more fully, offering more face-to-face contacts and ensuring that those people that need sexual health services, substance use services, or the health visiting service are getting those services as they need them, including kind of getting our immunisation programs caught up and supporting those families who have become new parents whilst in the lockdown, which must be very challenging. I will stop there and I can take any questions on my brief verbal report.
Thank you, Simon, for such a clear report. Have we got any questions? No. Oh, right, John. John, would you like to ask a question, please?
Thank you, Chairman. I've got a question. Are you actually involved? Oh, he's disappeared. Oh well.
No, I'm still there. Sorry.
That's all right.
Getting tea.
Simon, can you tell me? Do you actually, when the stuff comes through from the government, and our MP, our Prime Minister stands up and tells us what we're going to do next, do you then supervise the implementation of the of this item to the island and Hampshire?
So from my perspective, I'm the local leader for the for public health, and I oversee the pandemic management. So the government does give us guidance, and we support those people who need to implement that. It may not be a setting I'm particularly involved in, but I have the leadership. So if it's not going how we'd expect, I'd provide support for that setting. So for example, when the schools guidance came out, I worked very closely with education and Steve Crocker as the Director of Children's Services to ensure that schools were able to follow that guidance, which is in the main quite clear. Where there's confusion, I then provide support and advice to those settings, ensuring they understand how to implement that so that the island is as best prepared as it can be for coronavirus. So yes, in essence, I do support the government's guidance being delivered locally.
It's just that the reason I'm saying that is it must be difficult for you to, as things constantly changing, because the newspapers complain and then the Prime Minister changes his mind and then somebody else changes their mind. It must be very difficult for you to keep up with everything, to try and take it forward.
And I think that's my job, to make sure we're up to date with all the guidance. You're right, it does have particularly at the beginning of the pandemic, had a little tendency to change quite often, but I had a team that was kept up with that, and we have followed that very closely, and making sure that people understand that as it changes and as the messages change. So yeah, you're right, that's what we do, and that's my role.
I'm impressed with the way you take things in your stride, Simon. It must be very stressful, but you do a really good job, in my opinion.
Simon, I just wanted to say thank you very much. I think you do a great job trying to keep up with it, because I wouldn't like to try and do your job.
Many thanks.
Thank you.
Hi, John.
Good job.
Hi, John. It's Claire. Can I just add something to that,
Yeah,
please?
of course you can, Claire.
Just for me to say thank you to Simon, that he has kept us communicated completely as a cabinet. We have a Wednesday morning, very early call, and we also have like a code red call. Thank you, Simon, for ringing me today about half an hour before this meeting, because we have this thing that if Simon rings, I drop everything and answer the phone straight away. And he rang me just to ask if there was anything I wanted to add today. And I didn't really want to say it, was just to make sure it was a thank you, Simon. So he has worked the most, so has everyone under my portfolio, but Simon has worked ridiculously hard. And yes, it has been very difficult for him keeping up with different changes and stuff like that. But I have to say, you know, we are very lucky to have someone so senior who is working such a high level and can keep his finger really on the pulse of what's happening. So thank you, Simon, from me as your cabinet member.
That's well very kind. Thank you.
Well said. Right, now we've got Joanna and then Michael. Joanna, are you there?
I'm here. Yeah, I'm here. Thank you. So I just wanted to ask about how you're going to support local services with the recovery and restoration phase, because that's what people are most interested in now, particularly those who have been waiting quite a long time for health services to resume. So how are you, as I say, how are you supporting local services to get back to normality, and how important is that priority at the moment, or is it just a question of keeping people safe?
So I think there's two aspects to this. So if I can, so I have, I guess, a couple of roles. One is I'm managing the outbreak control plan, and that's really important that we prevent the spread of infection, working really closely with those people who are standing up services, working with the NHS to help restore. And I'm sure that Dr. Legg and the Healthwatch Trust, I think it's Kirk, will be talking about how they're standing up services in a safe way to ensure we further prevent spread of infection, because that's really important. So we're all working together on that through various partnerships. And with regard to the services I oversee myself, so the Commissioned Services of Sexual Health, Substance Use, 0 to 19, etc., we are working really closely with our providers to ensure they can stand up safely, ensure they can support clients in a safe way, and that services can be restored as soon as possible. And then working really closely with Chris Ashman, Director of Regeneration of the Council, because we both understand, as the rest of the Cabinet and CMT understand, that recovery and preventing spread are two sides of the same thing. Because if we have more infection, we're going to recover slower. If we recover quickly and infection goes up, it's not going to work. So we need to do that together, and we're working really, really hard on that to make sure that works really well together.
Good. Thank you. Are you okay there, Joanna?
Yeah, thank you.
Okay, Michael.
Yes, I've got one or two questions. The first question is this balance of opening up our economy against the fact we don't want to increase the infection rate, those two things. How do you, as the Director of Public Health, see as an island that we get that balance right? Because obviously there's a big push to get the ferry operators to open up. There's a lot of businesses, particularly in the hospitality sector, that are very worried if we don't have a summer season or try and get remnants of a summer season. And there's also a lot of people who are very frightened the visitors come, that's going to be, we're going to have a Leicester. So how do you see that situation, and how do we get it right, Simon?
You're right, Councillor Lee, it's a real conundrum, and I think, as I said, working very closely with Chris Ashman to ensure we do that in a slow and measured way. And we've seen the easing of lockdown over a number of kind of weeks and months of different things in place, and watching the impact of that. For me, we need to really maintain our social distancing. That's really, really important. I think perhaps that's a little bit forgotten in the community, that 2 meters is still key, and it's 1 meter if you can't do that, with some mitigation measures. We are working with all those businesses to ensure that they're able to prevent any outbreak, and as soon as there is any case, we can support that. As you'll be aware, I was dealing with a case on the mainland last week, worked very closely with that establishment to support them to make sure that they could be as safe as possible and open up as quickly as possible. So it's all those things together to support the businesses to be COVID safe, the 2 meters, the markers on the ground, how people are sitting in cafes and pubs, taking details, a number of things we need to do to support businesses to open up as safely as possible. And we have to really think about the distancing and the hand washing measures, which is still really key for preventing the spread of infection.
Thanks.
Thank you. I've just got a second question. There's various sort of talks, various papers are going around about trauma, and how the community or people in the community, right, are starting to see the effects of trauma. Actually trying myself to get out and into to have a meal out myself was extremely, I became very, very, very anxious in that environment. So I can actually see that there's talk about a trauma-informed approach being used in within public health. How do we install within the services in getting people to feel back to the new normal, or whatever the normal is, and to prevent those effects of trauma, anxiety, depression, etc., which such a pandemic creates?
Well, we'll let Simon answer that. Then we've got about 5 minutes left on this item, and Richard's waiting. Thank you.
Yes, many thanks. You're absolutely right that we need to support community and members with any kind of mental health issue or impact of anxiety from the kind of lockdown and where we've been. And we've been supporting through the recovery programme with the Isle of Wight Council and working with NHS partners a really strong approach to our mental health wellbeing, emotional wellbeing programme to support people, as you say, so that they can move forward to the new situation they find themselves in. Is absolutely key. And as you said, we are leading a trauma-informed approach across Hampshire, Southampton, Portsmouth, Isle of Wight to ensure that services are able to support people in a way that they understand trauma in whatever sense someone's has experienced that in, and that might be at a severe end or mildly. Really key for our recovery. I agree.
So we had a very good response from a similar question at the Trust Board, but I think that's, yeah, it's very important. Richard, last one. Richard?
Yes, right. Okay. I am a little bit, what's the word, confused. You've done a fantastic job. Thank you very much indeed. And yet on the ferries, I read that no one is going to be allowed to stay in their car. And I would have thought the ferries are one of the sort of worst places for passing on infection. Everyone has to go up and down the stairs for a start, so they're all handling the rail of the stairs. And I would have thought even just peace of mind would be so that people don't, so they could stay in their cars. Do you have any influence there, or you may not agree with me, but if you do you have any influence of the ferries? Because I think this is a mistake.
Good point, Richard.
As a layman.
We've been working very closely with the ferry companies to ensure that that they can support our pandemic response. And as you said earlier on, you can sit in their cars. I'm not privy to the laws that mean that people are moving on. If they get more people in the cars, I understand they need to put people up on the seating area, but also you have to wear a face covering, and that ensures that people spread it less to other people, and the face covering is about protecting other people, and also the social distancing measures in the area on the ferries. And having travelled on the ferries recently, you know, on the Red Jet, it's sitting far apart with a face covering, and you know, washing your hands as you get on and off is absolutely key. So it's those kind of things, and I can leave the ferry companies to work out their rationale, but I think we're working really hard with them to make sure that there's really good hygiene on there and people are following the rules of social distancing, which is key for this preventing spread.
I think you've made a very good point, Richard, and it might be something that if you like, we can take up further outside the meeting, because I think it stretches far wider than the remit and powers that Simon has. So thank you very much for that session. So we'll now move on to the next item.
John, it's
Hello?
Claire.
Hello, Claire.
Can I just add to that? We remember that, you know, ferries are public transport, and if you were catching a train or you were catching an aeroplane at the moment, you would be required to wear a face mask, a face covering, which is what the ferries are requesting people to do. So we need to make sure that we have a very balanced view to it when we're looking into it, that we're not saying, okay, you need to stay in your cars forever, that you are actually, the rules are 2 metre distance or suitable coverings, and the ferries are not allowing anybody on unless they actually wear a face covering. So we need to bear that in mind as well, if that's okay.
That's reassuring. Thank you, Claire. Right, so now I see from the trust, crikey, we've got Kirk, we've got Steve. Hello, Steve, haven't seen you for a while. And we've got Maggie. Maggie, how are you? So would you like to, who else have we got? And we got Joe Smith, Joe Smythe. Yes, so how fantastic. Would you like to tell us what's been going on in your world?
Okay, good evening, John, and good evening to all councillors and Joanne on this meeting this evening. I think obviously, as you've just outlined, we've got other members of the executive team who've joined us this evening, John. And what we propose to do is not talk to you about the preparation and the work that we've already done and that's now gone behind us really in wave 1 preparation, but we want to give you an update on really what we've been doing for our staff health and well-being, what we're doing with the antibody test, because I know that's a question that people have been putting to me, how we've been restarting our services, how we're managing social distancing and the face coverings across our organisation and the impact that's having on our patients and clients who are using our services, and really importantly for us, how we're planning for wave 2. So I'm going to hand over to Kirk. He's going to tell you about staff health and well-being. Joe's going to then pick up some other issues, as is Steve, and then at the end of it we'll take questions.
Thanks, Maggie. I'm hoping my connection is going to hold out, everybody. If it starts breaking up, I'll turn my video off. So I wanted to talk a bit about staff health and well-being. We've seen right across the NHS across the country a real focus on trying to keep frontline staff supported, healthy and engaged, because of the significant challenge that the service was anticipating as we prepared for wave 1. On the island, we've done a similar focus on health and well-being, and the upshot of it is that we have been really successful in engaging our staff And what we've seen is actually kind of unity of purpose across the organisation, which has actually led to improvements in morale and staff engagement. And we're seeing really high levels of staff engaging with the organisation through various communications and engagement channels that we've set. Some of the things that we did early in the response to COVID-19 to support health and well-being. The first was turning around our catering service at St Mary's so that we were providing lunches and hot food. We did that because we recognised how difficult it was for staff members to get access to food while all the shops were shutting down, and also the likely financial impact on families on the island when the second income in a household maybe was on hold. And so we felt that was an important gesture to staff, and it was fantastically well received. We've set the full catering service back up so people can pay for lunches as normal, but we're increasing the choice available and the hours that people can access food and drink. So it's something that we're looking to develop further. We made parking free for patients and staff, and currently that is still free. And we're looking at what we can do with that as a gesture to our staff, that we're on their side and supporting them. Throughout the pandemic, we've been really focused on giving staff the tools, in particular managers, the tools to look after frontline teams, and that's manifested itself in a health and wellbeing hub on the intranet, a new health and wellbeing bulletin, and a campaign being launched across the trust called Thrive, which really markets specific tools and resources, apps, and a service called Listening Ear, which is a counselling service that staff can access via text message at any time, and it signposts them to the relevant financial, emotional, professional support that they might need. So we've been really pushing that, and again the response has been great. We surveyed staff a few weeks ago to better understand how they feel about the health and wellbeing offer at the organisation, and the response rate was really encouraging, but also the feedback that we were getting. Staff definitely felt as the circumstances we were in was really visible across the trusts, and we're really keen that we can keep up the momentum in this space, because we don't want to lose that engagement we have with our teams. And a couple of the ways we're going to do that is through strengthening the staff recognition programs we have. So we have a program called Grey Ticks, where colleagues across the organisation can put nominations in where people have gone above and beyond or just done a momentum. Employee of the Month and Team of the Month was brought back towards the end of last calendar year, and we regularly see over between 50 and 100 nominations each month for that programme. And we're looking in a socially distant, potentially virtual way to have a staff awards programme in September. So even though the organisation's under pressure and there's a lot to do operationally, we're really throwing corporate resource, time and energy at celebrating staff and providing the support that they need to get their jobs done, but also to thrive while they're at work. So that's a very rapid whistle-stop tour of what we've been doing in the health and wellbeing space. If there's any questions on that, I'm happy to deal with them now, Chair. Otherwise, I'll pass over to my colleague to talk a bit more about the preparations for Wave 2.
Okay, any questions at this stage, or shall we just pass on to Joe? Pass on to Joe.
Thank you, and thank you, Kirk. really the first things I just wanted to quickly talk about, and the questions that I'm getting a lot of questions from the general public, is about how are we starting to restore services, how are we getting services back online, and sort of the key areas for us, the major one is elective surgery, so that's people's operations and procedures. So we've built up a considerable backlog because we haven't been undertaking surgery over the COVID period. So we're now working through that backlog in order to make sure that people can access their surgery in a timely manner. It's a difficult task because the restrictions imposed on us by COVID, so that means the wearing of PPE, separating emergency flows from elective flows, means that currently we're only at 66% of the theatre capacity we had before the COVID outbreak. That means the number of operations we can do is significantly reduced. Over the next month or so, we will be able to bring back all theatres online. So we're going to do some work that will allow us to keep the separation of flows and keep people safe and be able to bring all the theatres back online. Unfortunately, there is no cure or no vaccine at the moment. That means the other restrictions that we have to put in to keep staff and patients safe will need to remain in place, which will slow the number of procedures that can go through theatres. So best case scenario is by September, we will have 70% of the elective capacity back online. That isn't enough to start to eat into the backlogs. So we are working through the STP with our colleagues on the mainland and with the private sector to see how we might get additional capacity that would help us to start to get those waiting lists down. But at the moment, September, we will be up to 70% capacity. Over the next couple of days, we will be ringing 125 patients and asking them if they would like to have their procedure in the Care UK on the mainland, who is a private healthcare provider. We're hoping that we can get those 125 people to take up that offer, because as I said, the backlogs are significant. We have a similar situation with diagnostic testing, so that's MRI, CT, all of that. Again, the procedures that we need to put in place to keep people safe means we're only going to be able to return to about 70% of capacity. We have a brighter plan there in terms of we have the ability to bring in an extra MRI and an extra CT. And if we're able to do that and we can get funding centrally, we're confident we can clear the backlogs by March next year. So that would bring us completely up to speed and back to the waiting times that we had pre-COVID. So potentially good news there that we can restore all of that programme. And of course, the other area then, the big area is outpatients, high volume, social distancing, a big issue there. So what we have done there is we have relocated a number of services to allow us to create bigger waiting areas. We're reformatting the way the car parks work. That means that we will be able to have more car parking space around outpatients. And we're also looking at a scheme where we will ask people to remain in their car until their outpatient is called. Of course, the big thing that happened during the COVID was virtual outpatients, so ringing patients or having this kind of medium to see people so that they don't have to come on site. And we have some really ambitious plans around getting 40% of the outpatient activity in some specialties to be virtual over the next coming months. So that would then release more capacity and keep us safe. So they're the key areas. There's a lot of other things that are going on in the trust in terms of restoring, but the three big areas really around theatres, outpatients, and getting people back online.
Thanks for that, Joe. John, did you want to ask a question?
John, you're on mute.
I know. Yes, I would like to ask a very quick question because it's to do with what you were saying with outpatients. A number of the outpatient areas have been turned into wards, and a lot of the outpatients can't run because there's nowhere for people to go for their treatment. So are you intending to turn those wards back into outpatient areas again? Thank you.
There's a number of areas. So the main outpatients department, we're turning that back into an outpatient department. We're able to do that because of the configuration. So we can just simply take the beds out of the outpatient rooms and store them. So NHSI have been very clear. There is huge potential here for a second wave, and we have to be able to turn back on beds at a day's notice. We can do that with the main outpatients area. The other outpatients area, the building that we called Laidlaw, which had a number of clinics running in there. We've had to do significant work to make that fit as an inpatient facility. And unfortunately, we are going to have to keep the beds in that facility until at least April next year. We've been told that we have to do that. We have resited most of the services now, and by September, all of the outpatient activity that was taking place in Laidlaw will be resited in the north end of the hospital. So we will be back up to full speed for outpatients by September.
Thank you, Joe.
Just ask you one question on that. Laidlaw has been an area which has been used for physiotherapy for some years. And are you saying that the hospital won't be carrying out physiotherapy within the hospital?
Oh no, we will. So the rheumatology service, for instance, we've been able to move that up into the north end of the hospital. So we had a ward at the north end of the hospital that was an inpatient ward that actually we have been able to convert into an outpatient facility. So we've been able to move rheumatology up. We've been able to move up therapies. We're in the process of moving all the other services that were affected in Laidlaw either into that area or into other areas identified in the trust. But they'll all be restored, as in the outpatient clinics will all be restored by September.
Thank you, Joe. Joanna, you wanted to ask a question. Am I right?
Yeah, so I just wanted to mention that we're getting a lot of people coming to us that are really anxious about waiting for treatment or diagnostic services. So will you be communicating to those?
We will be writing out to all patients explaining what the situation is and where the waiting lists are. And the reason we haven't done that yet, to be honest, Joanna, is we're still working through what the implications are. We're trying to validate the list and we're reprioritizing people on that list. And once we have the reprioritization done, which will be on clinical need, we'll be able to give people a better indication of when they're likely to be called in. But it's certainly in the cards in terms of being able to do that.
That's great, because I think people totally understand, you know, the difficulties you've been facing, but it's the not knowing. And if they've been waiting 12, 18 months already, you know, they need to have some idea just so that they can adapt at home or, you know, sort of sort other things out. So yeah, communication is key to the patients. And also I was just going to mention communication around appointments as well. So I don't know whether you tell people they need to wear a mask when they attend the hospital letter, whether you give them an indication of where they can wait. I know some people have contacted us and they've had to go perhaps for a scan, but they've gone by bus and they've been asked to wait outside, so they're not quite sure where they wait, or you know, if they haven't got a mobile phone, what they do then. So you know, any information that people can get would be really useful.
Absolutely, and the reason we're expanding the waiting areas is because a lot of people do come by public transport, and we want to be able to bring those people into the building. That's also the reason why we're asking people that turn up by car if they would ring us when they arrive, then we register them over the phone and we ask them to remain in the car, because people do turn up quite a bit early for their appointments. So a lot of people turn up half an hour before their appointment. So we're asking those patients now if they would wait in their car to keep the load down in the hospital. We're also advising people that they have to wear masks, and at all of the entrance points over the hospital, they are now manned and there are surgical masks available for patients.
Thank you, Joe. Right, we've got about 5 minutes left on this, and so we've still got Steve to go, and then I've got Michael and John waiting for questions. So Steve, would you like to do your bit now?
Yeah, thank you, Chair. I think, as Joe has alluded to, we worked hard as an organisation to get into COVID preparations and achieved the reconfiguration of the hospital and the setting up of the hot and cold areas very quickly. As he alluded to also, it's quite difficult to be able to confidently come out of COVID and to essentially dual run for a period of time where we are still required to maintain some COVID preparations, but we have a desire to turn back on our planned activity. Obviously, to be able to support what we've been able to do, then we have had swab testing of staff and for patients. Patients requiring surgery are now isolating for 2 weeks and having a swab test 48 hours before their planned surgery intervention, and have been managed in quite a specific way. As Maggie alluded to in her beginning of the presentation, over the last month or so, we've also been introducing antibody testing of NHS staff, and that to a certain extent is of academic interest, but it provides us with a good insight as to the proportion of our population who possibly have developed COVID, some of them without actually developing symptoms. There is a requirement for all NHS staff to be tested by later this month. We are reasonably confident that we will test all staff who want to be tested, and to date we are probably up around about 1,800 staff tested. And interestingly, of those who have been tested, about 8% are coming back as positive, the vast majority of which have had no symptoms. And I guess Simon would probably confirm that actually the only real way we're going to come out of COVID confidently is probably when we've got a vaccine that is effective at reducing the disease in the population. So sadly, I think COVID is going to be with us for a while, and the balance of getting COVID patients or protecting staff and patients from COVID, but delivering our other activity in order to try and reduce the risk associated with delays is going to be a challenge. And that's all I'd like to say at this moment in time.
Thank you, Steve. So we got Michael and John, and then we'll have a 10-minute break. Michael, are you there?
Yep. Thank you. First, can I actually thank you all for a fantastic job you're doing, and the care that you are taking. I think you are real heroes and heroines, and I think all of us would want to really thank you for all your work. The two areas that I would like a little bit of update on, one is mental health, 7 acres, and because obviously through this people with serious mental health issues have obviously still been there within our community. Has there been an increase use of services because of COVID? And has there been dual diagnosis of COVID and mental health? And how have you been able to support that? And I'll give you my second question now, so you can have, is about when people travel that come in through A&E and then have to go on to for heart operations or specialist children's at Southampton General. One of the points that I'm getting from residents is often an example recently of a single mother who ended up having to go over and completely lost contact with her family and her sort of support needs. There's how we communicate within the other hospitals and such, during the pandemic, to make sure that there is support for those patients. So those particular points I would like to raise.
Now we can have a brief response to this, or a response in writing, or both. But I think that both of these items were covered at the trust board, if I'm not wrong.
You were, John.
Yeah. So maybe I mean, the reassurance, Maggie, is that you're aware of both these issues and you are dealing with them. I think, if I'm not speaking out of turn. And we can refer, Michael, to your response already in the public.
John, and I don't, Michael, and to do the question justice about mental health in a couple of minutes, I think would really be probably a disservice to everything that's been done. We did have a very comprehensive discussion at our trust board last week, which John was present at. Yeah. I'm very happy. Steve, Deputy Medical Director on the call, can give you a minute's worth of what we've done. And we didn't bring anyone from mental health tonight onto the call, but we can arrange for a separate conversation, because I think we've seen some fascinating things within mental health and the way our community's responded. And I suppose, as Simon would be able to say, rather predictably, we're now starting to see some more effects of COVID than we saw right in the beginning, when we were going through the wave one. So I think some of the comments you made earlier around yourself going out for a meal and the effects you're feeling now, I think we're seeing that within some of our community. But Joe will talk a little bit about transfer in a second. But Steve, do you want to very briefly touch on some of the mental health issues?
Thank you. I think the whole pattern of illness in general changed during COVID. We saw an exponential decrease in the number of patients presenting to the trust in various forms, including ED, and the numbers fell dramatically. I guess some of those changes were also experienced in primary care. What we've seen as we've come out of COVID is actually a return to almost pre-COVID levels of attendances, but there certainly is an increase in patients presenting to the emergency departments with mental health problems as we've come out of the initial crisis. So yes, in answer to your question, we have seen an increase in number of mental health attendances at ED. Yes, we are aware of the challenges that face, but I think our improving mental health services in general have been able to provide that cohort of patients excellent support. So I'm proud of what they've achieved and what they will continue to do in these challenging times.
I think the questions that Michael has raised are really important, and they do refer to ongoing concerns. And it might be a good idea if we were to have an informal meeting just on that subject and the issue of the fallout from the virus. So, good question, Michael. John, you're the last one. Turn your microphone on.
Thank you very much. I always like to be the last one. Thank you, Chair. I was very interested in the way you were telling us about people waiting for treatment at the hospital. But can we have, as we go on, as you manage to put this in place, are you able to keep us informed of what's happening? Because people visiting the hospital don't like to lose their appointments, and they like to make sure they're, as you say, they get there an hour early to make sure that they get treatment. And the other thing is, how do you intend to manage the people coming in for blood tests? Because I mean, it's a fast-moving situation, and I wonder whether it's possible you could talk some of the health centres on the island to actually take on the responsibility of doing blood tests, which would take a lot of pressure off. And also
Joe is
other
nodding
things
his
like,
head very knowingly, John. So let's hear what Joe's got to say.
I'm sure he's got all the answers there, Chair.
He's a man. Go on, Joe.
Well, if only I had all the answers, you know, we would be fine. But in terms of, you're absolutely right about the blood test, John, in the hospital. It's a high volume activity. And we've been working with the CCG about how we can, it's a community based service. It should be in the community anyway. And this just is a catalyst for making this happen. You know, there's no reason why people should have to travel a great distance to have blood taken when that could happen in a GP service or in a health centre anywhere else on the island. So we are working with the CCG to do that. And at the moment, while the blood service is still at the hospital, when people turn up at the front door, we're managing them. So it's a bit like a supermarket now. If you come and there's already too many people in the phlebotomy department, you have to wait outside until they go through. But that's how we're managing at the moment. But the future will be much better, John. It'll be a much better service for people in the community.
Very quickly, could I also ask you, when you're negotiating for blood, that you ENT tell me when I went in there that they would like more people to do when they're having their ears suctioned out. Could be done at the health centres rather than coming into the ENT to have it done there. And there are a number of health centres that already do it. Could we persuade the rest of them to take on the job?
We could bring that up on the next item, John, probably more appropriately when we talk with the CCG.
Well, I just thought that their mate here would actually be very good at pressuring people into doing things they don't want to do.
It's a good point, but it mainly rests with the CCG. So,
John,
yes.
John, if I may, just before we finish with our trust, could I just say that I would like to take the opportunity through this meeting to commend to you all of our employees and those of social care. I know Councillor Howe mentioned earlier, Councillor Lilly gave us his thanks, but I personally would have said in many public forums just how impressed and humbled I've been by everybody's response on the island, and it's the first opportunity I've had to say this to you collectively. I'm in my 39th year in the NHS this year, and I can honestly say that the way our staff across the NHS and social care have responded on Ireland has been truly incredible, and I want to commend them to you and also to use the opportunity to give my personal thanks to everybody.
Thank you, Maggie. I know that will mean a lot. Right, 10-minute break. Thank you very much, everybody. See you again in 10 minutes.
You bring the coffee round, John?
Oh, if I could do better than that, John.
Yeah.
Yeah.
That'd be nice.
Yeah, would. So, there we are. Oh, well, that wasn't too painful, was it?
Get upset, I found this on protectors or whatever it is.
John, you need to be on mute in the break.
Yeah, your mic's still on.
Oh, right.
Still on.
Okay, let me see. How's that?
But we're all glad it wasn't too painful for you.
I think you're muted, John.
Thank you, Richard. Yeah, I'm unmuted now. I don't want anybody to think that I'm slick at this sort of thing, because I spent the whole of one meeting trying to log on, and by the time I logged on, it was finished. So I've come into County Hall to use a council computer with support from 2 officers to make sure nothing goes wrong, and it nearly did.
And Andrew had the same problem.
Yeah. No, it's far better, I've got to say. Megan and Paul, fantastic support. So are we
just going to wait? I think Sarah's just about to take the polling screen down.
Right.
Yep, here we go.
Here we go. I think we're back live again. Welcome back, everybody. Are we all here? So jolly good. Right. So the next item on the agenda is the CCG. So I'm assuming that's Michelle. Is that right? Michelle, are you there?
Yes, I'm here, but I think actually Alison's leading on this.
Oh, Alison. Where's Alison then? I didn't see her log on.
Alison?
Alison, are you there? Is Alison logged on?
Yeah, she apparently is logged on. She's come in on the NHS log, so I'll just text her.
I spoke too soon, maybe.
She needs to come in also on the island.
I normally have.
That's what we did when we first joined. We joined on the NHS, so we could see you, but we couldn't join in any of the meetings. So luckily, Kirk recognised the error, and we joined us under the Isle of Wight Council. So it wasn't a disaster for us, but nearly.
Well, if we're having problems with Alison being able to speak or log in, then maybe Michelle, you could stand in.
Yes, I'm back.
Yeah, okay. Sorry to put you on the spot. But
That's all right. I don't mind being put on the spot.
John, I think we can also see Councillor Tyndall's Skype on the screen as well. So I can't.
Brian, you're sharing your screen, Brian.
It's not live.
Oh, right, okay.
Yeah.
Stop sharing.
That's better.
Right, better.
Right. So we'll try Alison again. Alison, are you there? No. So Michelle, if you be so kind.
Right. Let me just get the report up, because as I say, I wasn't expecting to do this, but I'm quite happy to jump in. There we go. So what sort of report are you expecting today?
Just Michelle, it's just really the opportunity to update us, and I know that we had a very, very good informal meeting with Alison over Teams, and that was one of my disasters because I think it took me half an hour to log in or something. But anyway, Alison's here now.
Oh, Alison.
Apologies for that. I had
That's
to.
all right, Alison. No need to apologise. We all know what these things can be like. So we were just seeing if you could give us a brief update of what's happened in the CCG world.
Sure. Firstly, I'd like to start by sharing how my team have responded during this period. Within the CCG, we've actually done a piece of work to look at the amount of time we're spending in different areas, and for those services, the CCG business as usual, we've reduced our workload down to approximately 30 to 40%. And that's every member of the senior leadership team. And that was to enable us to do 2 things: to work within the system in a very different way. So that was working with health, social care, the trust, voluntary sector, and also the resilience framework process that we found ourselves in because of COVID, but also spending a significant amount of time working with our primary care colleagues and our primary care networks. And that was enabling us to be able to respond in a way to in the delivery of services rather than necessarily in purely commissioning. Though obviously we had a requirement to ensure that we also were able to make sure that we were not a delay in whatever was needed to be stood up, that the monies that were going to be released to our system would be able to flow through quickly, but also to ensure that we did keep a record of our decision making and where the money went, and that we had done some due diligence regarding good value for money, as you would expect. I will just start to do a sort of quick briefing on the types of things that we have been doing over this period of time. So obviously the primary care have been working in a very different way. A hot site was set up fairly quickly to enable us to see patients who were considered to be potentially COVID patients, either because they had symptoms or because someone they knew they did. We also stood up very quickly virtual consultation with support from the Trust, who helped us to no end to get that in place to enable patients to continue to be seen, but from the safety of their own home. And we significantly increased very quickly the use of telephone and video consultations, and that continues today. There was an immediate triage of all people, and that meant that they could be sent to the right place for their care, right person for their care, but also it actually reduced any waiting time. So the level of anxiety that some people were feeling was significantly reduced. The provision of prescriptions was done very quickly using electronic prescriptions rather than paper, so reducing again the burden of having to come into the practice, and working with our local pharmacies to be able to support the quick turnaround of prescriptions. And just bearing in mind that within our role within the system to support both the pharmacists, the dentists, opticians, to enable them to function while they could, but also to support them for those emergencies that may need to be seen, we continue to do. We worked with the ARC cell on the island to identify those who are shielding those vulnerable patients and to make sure that their ongoing care plans were able to be continued, and to support with any exceptional needs that they had, and supporting the ARC group to be able to do that. We did reduce routine activity such as health checks, smears, annual reviews, etc., as you would expect as we were responding to an emergency situation. And we also did a piece of work, a very close joint piece of work in the support of care homes with Carol and her team, as well as the Trust, to enable us to very quickly align GP practices and a clinical lead with care homes, and to support the varying piece of support work that were required during this period and continues to enable care homes to provide the invaluable support they do for their residents. And I'll move on, if I may, to our role within the Acute Trust and community care. We were very supportive of the field hospital, released a member of staff to support that solely. In fact, there were several members of staff released to support that implementation, and we continue to work with the Trust on a number of recovery programs, hopefully in a close way, so that again we're maintaining the split of our workload, if you like, across both the system, the PCN, and also the CCG, working closely, as Joe was saying, with the community division and how we can do services differently, because we've learned a lot through this time, and what we want to do going forward is to make sure that we don't revert back to old ways of working, but keep very much working in new ways. Working with community services and also the testing sites, Medina, and also looking at how we can support with the mental health. We have one member of staff who's working solely on that piece of work, and also others who have joined in to help with the mental health transformation as we go forward.
That's James, isn't it, Alison?
Yeah, but James and members of his team actually. There are quite a large number who are supporting with that, but James is leading on that piece of work from a CCG perspective, working with the Trust and Solent as the partnership provider. But it's broader than the individuals. I think what you're hearing from me, hopefully, and hopefully this will resonate with others on the call, that working in a very different way, we got an awful lot done, and we got it done quite quickly. And we want to continue doing that because it's been the right thing to do. And I think our community has benefited from the very close working across all providers and with the voluntary sector. And we want to continue doing that because it's had such benefits, that there's a real willingness and a drive from the team. We were even talking about it today about how we continue this because they found it very beneficial for themselves, but also they can see the outcomes that are being achieved and want to continue to do that. There's been a
this is the silver lining then, Alison.
Yeah, I think so, but I think it's just really it's really enabled us to really focus on outcomes rather than process, and that's important. There is some process. We're a statutory organisation just like yourselves are, so we do have requirements that we have to fulfil, but actually if we can make them lean, if we can limit the bureaucracy we put around that, that's for the good. But you know, there's a huge amount we need to do to continue this work and to continue the transformation that is already in place. And as Maggie, Joe, Steve and Kirk were talking about, you know, there's still quite a great deal to do in terms of next steps, but also planning for phase 2. But how we want our recovery to look going forward, how we switch services back on, working in conjunction and in partnership with colleagues across the system. And that's both with health services, but also with our social care colleagues, and particularly with children's as well. During this period, we got some significant news about a bid that was put in place that we've had supported. And again, it's the transformation of services that allow us to make sure that people are being seen in an appropriate time in the right place that's right for them, and that we limit the gaps as much as we can by working in a very different way. And I know you've heard some of this, so I don't want to repeat myself, but just wondered if there was anything Michelle wanted to add to that very quick canter through the services.
Thank you, Alison. Michelle, was there anything you wish to add to that?
I would just like to say that actually what COVID has shown us is how quickly we can make changes. And I think lots of people have seen that actually we can make significant change, but still have safe services. But actually see that actually that can be done, and often changes often take quite a long time. They go through several committees, and people sit back and they don't see those changes. So I think that's been quite beneficial for both primary care and community services in particular.
Well, it's great to hear that you've got a new focus on objective with process only as a supporting mechanism. You're talking my language now. John, what did you want to say? Switch your thing on.
Will. Thank you, Chairman. I have a question that I asked just now about outpatients, stuff like ENT and blood testing. Is it possible to actually give the opportunity for some of these things to be taken on out in the health centres rather than having to go in the hospital? Blood testing especially, but also treatment on people's ears with with suction treatment that is done in some of the health centres and probably relieve some of the pressure on the hospital.
So John, we are, as Joe shared with you, exploring where blood testing can be done and how that can be done, and we are open to exploring any of those options and how we make that happen. I couldn't say yes categorically now, because we'd have to work with our partners in primary care to look at that, and we also have to work with the trust to understand how we want to make that work, because we do have to look at the logistics around all of that, but it's certainly something we've already begun the conversation about in terms of blood testing, and we're looking at that model, and we can certainly look at the other services, including the ones you mentioned around the ears. That's not a problem at all, and we're very open to that.
You're on the money, John.
Alison, just ask you one thing on that. If it does happen in the health centres, can they claim money to run it, or do they have to finance it out of their own budgets?
No, they can't finance it out of their own budget. It doesn't sit within that type of contract, as I understand it, but we certainly need to, that's why we'd have to explore it, work with colleagues to see what the art of the possible is.
Okay, thank you, Alison, appreciate it.
Good answer. Right, now we've got Joanna and then Michael.
Hi, yeah. So I absolutely agree with John that people are desperate to get blood tests, and it's really difficult having to go up to the hospital, particularly if you're travelling from across the island or you've got young children that are being looked after. But also, I wanted to raise the issue of B12 injections. We've had a huge amount of feedback, and there's been a huge amount of feedback on social media as well. It's a huge problem for people. But the problem we've got is that it's an inequitable system. So some GP practices are getting really good feedback and some are getting really poor feedback about the same service. And I won't name and shame, but I will say that the top two are Tower House Surgery and Ventnor Medical Centre, and they are providing really good services for people around B12 injections, both with regards to communication and also to giving the injections. And then you've got GP practices on the other end of the scale that are not giving injections at all and are providing really poor information to patients. And it's causing a lot of upset. People are getting really significant symptoms now as a result of not having their injections. Some people are being advised to go online and buy medication, which is not the best advice, but that's what their GP practice has told them. So it's a real issue, and I wondered whether the CCG would be able to produce some guidance for patients on what they should be able to expect.
Alison, shall I just start this?
Yeah, go for it, Michelle.
So when we were at the start of COVID, we had advice from National Haematological Society about what to do about B12 injections. And the advice we had at that point was that all injections would be suspended and patients would go on as a stopgap oral tablets, so oral vitamin B12. And that was just for a certain period of time until we could resume services. And I think probably what's happened is that people are still doing that when actually we've now moved on, and B12 injections can be administered under safe COVID safe conditions. So I think what we need to do is support people to have an equal service across the island, and it's not fair, as you say. You know, I'm proud that Tower House is in the top, but you know, so I am really proud of that. However, that's not to say that across the island it is unfair, and every patient deserves to have the same service. So I'm sure that the CCG can work with practices in order to make sure we have the same sort of system going on now.
If I could just interrupt, I know, Joe, that you've been speaking to Tracy Savage about this, and I know that that work has already begun. So hopefully you should see an improvement shortly.
That would be great. Thank you.
Good. Okay. I mean, you'll get whatever support you need from us in whatever help that may or may not be. but we'd be happy to give you official support if you so wish. So, Michael.
Yes, before I go to my question or something Alison raised, let's make a comment and declare as a Isle of Wight Youth Trust trustee that I actually think the model of partnership between Isle of Wight Youth Trust and Barnardo's and CAMS really gives a good model for the future of how the voluntary and public sector working together. Because actually right through COVID, those three have worked very hard to get a new service of mental health for young people on this island. So, and work very closely obviously with the CCG. And I think that we should actually look at that example of model in the future, because I think it's a really good one, although I'm obviously slightly biased about that. Particular point is about the voluntary sector. We've got a new kind of health partner that has emerged really through all the 27 community hubs across the island who have worked on the ground, right, in their communities, some led by the parish and town councils, some led purely by new community groups, faith groups that have actually really worked in partnership with the public sector in delivering support at that grassroots sector. So a good example around mental health is you've had a number of those services providing telephone support that have then escalated up to your other services with that. So my question is, how do we capture that? That has been a new enlightenment for the future.
Time to answer, because we're running up to the 20 minutes on this, and a good question as always. So yeah.
Shall I?
Yeah.
So I think Michael's made a really valid point, and I think we started to get close to understanding what the voluntary sector do just before COVID hit, when we were visiting some of the community support centres and meeting some of the voluntary sectors, and personally I've been to several now, and I think absolutely I completely agree. What I'd like to suggest is we come back to that, Michael, and we do it offline and try and look at how we do that, because there are many examples around the country of how particularly the CCG can work with the voluntary sector in terms of commissioning, and also how we do that in an integrated way with our partners on the island, using the voluntary forums, using the connections that we all have across the system to really make sure that nobody is left out, because there are a number of voluntary sectors who may not be involved so much, because they vary, as you know, Michael. There can be one or two people doing something to a larger group doing something, and I think we want to make sure we're completely inclusive. So I think there's work to be done, and I'd like to suggest we come back to you with a proposal when we've had an opportunity to speak with the voluntary forum.
We're featuring this at our next formal meeting in September, so
okay, perfect.
We can do a little bit work in between. So yeah, good question and good response. Right. Okay, so we'll move on to the next item, which is adult social care. Now, we've already heard from Carol, but we're always like to hear from her again. Carol, is there anything you want to tell us?
Okay, thank you. So listening to our colleagues' contributions this evening, I've just looked up a quote of a pastor whose work I have followed for many years. He's a Quaker, and it's a guy called William Pollard. He's dead now, but he's a very famous preacher. And he said, learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. And what the COVID pandemic crisis has revealed to all of us working in this space is that what we did yesterday is simply not enough and cannot be the only thing we use to inform what we did yesterday for what we do today and tomorrow. Adult social care, I'll deal with adult social care and housing slightly different. We have had to continue, very obviously, meeting the needs of people within the community. Not only working, as you've already heard from Joe, from Alison, with our partners in health, for instance, around meeting government's requirements about people moving out of hospital from the 19th of March. As quickly as possible in order to free up very necessary hospital beds, but we've needed to continue to support the people within the community. So I've already told you this evening, on average, we serve at just over 3,000 people every week. So in the last 4 weeks, ending ending May, I don't have June's data yet. During that month, we, for instance, did 239 reviews of people. We undertook completed 240 assessments of people. We responded to 286 safeguarding referrals for people. We helped support 173 people in temporary housing. And we've just listened to Alison most recently about the community cell, and the work there has been tremendous. But to put some numbers to that, basically in the week ending, up until the week ending the 10th of July, 8,892 calls to the helpline, 5,451 people shielded. There are 73 care homes on the island, and we have provided daily calls to each and every one of those care homes. We have provided, as your pack shows you, over 256 items of personal protective equipment for when those providers have not been able to undertake their own, to secure their own. We've been under huge scrutiny from government, and most recently government has basically created a social care task force headed up by David Pearson. I spoke with others to David earlier this afternoon, and we had on the 29th of May, and did this very much in partnership with colleagues in the CCG and with our partners, with our care home providers. On the 29th of May, we had to submit a care home support plan. And basically, of the feedback that we had around that, there were 6 pillars of what care homes needed to be doing. And the feedback that we had, and Alison attended that meeting with me, was, and I quote from it, it was that it was excellent, that the feedback from the providers in particular stood out, and that actually what we were doing was very comprehensive. We were told that actually our plan was the best in the whole of the South East region in terms of the support that we were providing to our care homes. So with that in mind, because I know there's been some controversy recently, I was on annual leave last week, but I was keeping a weather eye on things, and I could see that there was some controversy within the county press around most certainly what is accurate data about when the last outbreak in a care home took place. An outbreak, committee members, is defined as 2 or more people. And there's often a delay because actually the tests are most effective 72 hours after you see symptoms evoke. But we have basically, as of this afternoon, there are 5 people who registered managers of care homes are saying have already been confirmed as having COVID-19. But of those, basically all of them were diagnosed more than 21 days ago. So basically we are doing extremely well with regards to outbreaks from care homes. So what have we asked of the care home sector? And you will see that in some of my slides, I'm making some very deliberate and provocative, perhaps you might think, statements, because there will be learning from this. And one of the learning is that actually the adult social care plan was not published until the 15th of April. It followed on from things such as the 19th of March, discharge to assess requirements. And did hospitals release, and I know this was asked earlier, were people discharged from hospital into care homes without having been tested? Yes. Is that because anybody in a hospital, including this hospital, thought that was a good idea? Frankly, no. It was because actually the testing was not made available. And so it was until the 15th of April that actually government itself said nobody should be going from hospital into a care home without being tested.
Locally, led by Simon, and also I would absolutely say supported very much by Alison. There's been huge efforts to get the testing of care staff done, but quite frankly, it's not been good enough. It's taken far too long, and the chair of the task force himself this afternoon, in a national call that I chair every Monday afternoon with DHSC and the task force, absolutely, I know that the task force is still having to argue really strongly about getting that testing done. Now, and it's all care homes have had now testing of all of their residents and staff, but it's the repeat testing. It's what you heard from Steve that's really, really key here. It's not good enough to be tested once, but we need to be doing it time and time again. The other thing that we need to be thinking about is we will see a surge in demand. So we did see a slight decline. We're back up to near normal levels, but I think we will see a huge surge, and that is what everybody is suggesting, of referrals into adult social care. I'm giving you my data about activity, but there's been a slight decline of referrals in, but a marked decline in the numbers of safeguarding referrals coming in. So even though we undertook 286 safeguarding referrals and received those in May, the normal numbers that you expect that we receive is 340, 350. So care homes have been very much needing to prevent people entering because of very good infection control reasons. But I think we are now at the stage where we need to be thinking about not only life, but actually also quality of life. So later this week, government's going to be publishing new guidance about visitors to care homes, because actually people have suffered, not at the hands of staff at all. Staff have replaced family. I could, some really heart-rending, and I know that my cabinet member relayed to Scrutiny Committee about 3 weeks ago the one example of feedback actually from a district nurse about what she had seen carers at a care home do. Families have not been able to go in, so carers have been literally the last person that these people who have died have seen. They have been the ones whispering to them, holding their hand, trying to nurture them in their very last breaths. And that's not being over dramatic, because families have not been able to be there and to do it. So care in adult social care is so often commodified. It's how long does a home carer go in and help support? How many minutes a day? How many hours a day? How much does a residential care placement cost? So care is so often commodified, and it needs to be. It's public money, it needs to be. But actually what COVID has demonstrated, and I think John, Councillor Lilly, I think it was you who used the word hero and heroine a bit earlier on. But what COVID has brought out to me is not the commodification of care, but absolutely the emotion of care. We have expected huge amounts from the social care workforce. And I think that if there's a positive thing, it's absolutely ensured that the public perhaps understand the labyrinthine rules around social care and complexity better now than perhaps ever before. But moving forward, more of the same is not going to be an option. So we know that government is going to be looking at the social care reform. I hope and pray that it does also look towards the resourcing which is necessary for adult social care. And you will note from the beginning of the slides that I've given you, not what I am saying, but what august bodies such as the House of Lords and select committees are saying about the future funding of adult social care and just how much it is currently under-resourced. The final thing that I just wish to really mention tonight is housing. So at one stage, we were supporting an additional 81 people who have presented themselves as homeless. And part of the emergency legislation government introduced was an easement of the Homelessness Reduction Act 2017. And ordinarily councils have 2 tests which somebody have to basically fulfill before a council regards them as homeless and having a duty towards them. The first is that they are not intentionally homeless, and so you have to determine that somebody is unintentionally homeless. And the second is that they are in priority need. The easements and the emergency legislation were that neither of those 2 tests needed to be met. And basically the mantra that government made under the very charismatic leadership of Dame Louise Casey was everybody in. But what we've needed to do is not bring everybody in to dormitory shared type accommodation. We were given 48 hours by government to clear all dormitory type styled shared accommodation and to find individual rooms which could be entirely self-contained, i.e. with their own bathrooms, for those people who were in what was our emergency winter shelter and the Salvation Army dormitory accommodation. We had on top of those individuals, as I say, an additional 81 people who came across our door. So we needed very quickly for the dormitory, the people who were currently being temporarily housed in our emergency winter shelter, which has been a massive success, by the way, as well as the wonderful Salvation Army and the dormitory accommodation that some of their accommodation comprises. We successfully moved those people within 48 hours, but we have accepted in others. And one of the great things, and I'm going to finish when I do this, is to show you how, you know, you can't think the same, is how we've come together as partners. So it is a caricature to say that all homeless people are, you know, have other problems such as mental health or substance misuse. But it is fair to say that a far larger proportion of homeless people than within the non-homeless population do suffer from very poor mental health and also from substance misuse. What we have, and we've needed to see, and Steve reflected this earlier on in a question, as well as Simon earlier on, we've needed to change services, as we've heard around our GPs, around doing things virtually, so too a lot of our mental health therapeutic intervention and also therapeutic intervention from substance misuse services have needed to move to that virtual mode. So one of the wonderful things that's happened during COVID is there are now thrice weekly meetings where housing, adult social care, children's services, inclusion, and the Trust mental health services and the police attend to look at the wraparound needed to be given to the most vulnerable people amongst that homeless population. Since we've started to do that, we have seen a drastic decline in the numbers of concerned citizens out there about the additional accommodation we needed to provide to the homeless people. And equally, we have begun to see some major success. An example is that there is a rough sleeper who has been sleeping on the cliffs in Shanklin, in that area, so well known to some of you I know, and has got into the media as well. That person has now moved into their own accommodation. They have not done so, and not wished to do so, for the last 6 years. Because we've worked together as one, we have secured that success. That's one person, and I recognise that I'm talking about one person. But if we can do that for some of our most complex citizens on this island, then actually our ambition, as a consequence of the different ways of working foisted on us, forced on us, which has made us take away the armour and the plating that we put around our individual services as individual organisations, the fact that we've had to do that is absolutely the mirror that we need to continue to put up and shine toward ourselves
to make sure that we continue in the same vein. So I'm hugely proud, as I've heard Maggie and Alison and others say, around the magnificent response that has been given. We know that COVID has disproportionately affected the most vulnerable in our community. It's shocking figures. If you're over 80 and you've had COVID, you literally are 70 times more likely to have died than an under 40-year-old. That's not me saying that, that's Public Health England. So it has demonstrated, similarly, we've heard around its disproportionate impact on people from Black and Asian and minority ethnic communities. COVID has made us work in different ways. We have to hang on to it.
Thank you, Carol, for an excellent briefing. Joanna, then we've got, who next? Then we got Michael, then we got Richard. So Joanna. Joanna. Yep, here we go. No. Okay. Joanna, are you having some difficulty there? Shall we move on to Michael and come back to you? Yeah, let's move on to Michael and come back to Joanna.
Thank you. Thank you for that, Carol, and thank you to all the staff involved, and I particularly we do need to thank all the care workers working in the home who are again unsung heroes, quietly getting on with that and in a very difficult job, and obviously also the personal assistants that have been continuing through this time. I will actually point out on the homeless. We had a similar case in Ryde, and again that person is now in their own home. So thank you for that. There's some good evidence and stories of success there. The particular question is a difficult one around the discharge of people, because you've had a number of people who are discharged at a particular rate where that you've had to guarantee a bed, and from what I have observed, quite successfully. But then there comes the thorny thing that after the 12 weeks that particular homes are getting a particular high rate, then it becomes to the needs of that individual and their financial means. And if they are basically poor, then it's quite likely they're going to have to be moved to a home that can actually accept the rates that you are able to pay. And I suppose my question is, how are you going to manage this? Because some people have been in, it's literally moving someone from a 5-star hotel to perhaps a 2-star hotel. How do you manage that difficult situation?
Thank you. Well, number one, what I'm delighted to remind the committee of, because I think I did bring this news as soon as it happened, is that there's not a single care home now on this island that's rated as inadequate. And that was certainly not the case, even 2 years ago. So there's that. So in terms of the analogy of 5-star to 2-star, I think most care homes will probably disagree with that. So what have we done? So basically, NHS and councils have been given additional funds by government in order to support the understandable imperative to get people out of hospitals in order to free up those valuable hospital beds. We worked with the CCG, and it's absolutely right to say that additional money has been given. So for people who are already in receipt of adult social care, we've had to recognise that providers have very much experienced additional costs. And I was heavily involved in this nationally. guidance, so it's not policy, but guidance was issued by ADAS and the Local Government Association to all councils, suggesting that basically councils needed to uplift their rates by 10%, in order to support providers to meet the additional costs. For instance, we've seen hyperinflation in PPE costs. What also it introduced was a system, and it is thinking of extending this, by the way, throughout the entire winter, and we should get clarification of this, I hope, within the next, well, we've had some clarification. We will expect to see the formal policy, I think, published in the very near future. The second bit of money went to the NHS, and basically what government said there was that the NHS needed to fund, and initially it was for 12 weeks, but it's been extended since then. It needed to secure beds and other care for people who were new service users in order to support two things: expedite their discharge from hospital and avoid an admission to hospital. So since basically the middle of March, the CCG has assumed the financial responsibility for new service users of adult social care, and adult social care through the council has given an additional 10%. So basically I can tell you that the 12 weeks additional 10% for me was 898,000, and then in addition to that, government provided us with 2.45 million to the council for the infection control fund, and the first swathe of that came in at the beginning of June. In fact, it came in on the 30th of May, and the second will arrive this month in July. And that money had to go straight out to all providers. So providers have had, for new service users, in order to avoid their hospital admission and expedite their hospital discharge, funded by the CCG. And what we did with our providers, with the CCG, was we got them to evidence what they felt within COVID were their true costs. And what that came back at was 1,020 per week, per person per week for a residential bed, and £1,375 per week for a nursing home bed, and £25 per hour for dom care. So for new service users, that is what's been funded. For existing service users, the council adhered to the guidance from LGA and ADAS, 10%, plus we have given an additional 1.2 million into care providers, and a further 1.2 million will be going into care providers in July. So how do we then get back to what are the contracted rates? Because basically the CCG rates that I've just described for new service users are almost 60% higher than the contracted rates for residential and nursing homes. We have been really clear, and we have successfully moved people home from those who've been placed into residential care. So of all of the discharges which have taken place since March, just over 1% of all discharges, whether somebody needs any ongoing support or not, 1% are supposed to go into care homes. Now we've been a bit above that, but where we are different and we're performing really well is we have a dedicated team who are going in and working virtually to review, and we have drawn people out. In addition, the CCG has funded, for instance, in terms of step down, it's the service has ended now, but it used the Premier in and worked with us, and we brought in a company that we use for 24-hour care with living carers basically, and every single one of those service users has gone home. So the important thing about this is that people have gone into care homes as part of their recovery, and also so that they could meet the 3-hour requirement of once somebody is deemed to be medically fit for discharge, they should be out of that hospital. Very understandable, you know, in the circumstances. So what we've needed to do is to ensure that the way in which we've commissioned, it's crystal clear that people move through that rather than it's a full-time permanent placement.
Thank you, Carol. Right, we're fast running out of time. We've got another couple of questions, Joanna and Richard, and then we've got Joanna to present the Healthwatch. I don't think we're going to have time to look at our work plan, so if we can keep these as brief as we can, please. So Joanna, do you want to go with yours?
Thank you, John. So I just wanted to go back to care homes. So I've spoken to some managers and staff who've done an outstanding job, and they've literally lived, breathed and slept COVID for 4 months and will continue doing so for the foreseeable. My concern is that many care homes are now effectively closed environments. So they're not having visitors, they're not having the usual district nurses in, doctors, CQC are not doing routine inspections. The quality team are not doing quality monitoring, quite rightly, because of the safety risks. But this leaves residents very vulnerable. And my worry is that care homes will first and foremost want to protect the residents and keep them safe, and they won't be looking at their quality of life. As Carol was saying, you've got to look at people's quality of life. Residents, many of whom do have mental capacity, have the same human rights as everybody else. And if government guidance changes and we can all visit more people, then it's essential that residents in care homes are awarded the same rights.
I think
and
we're
there are
pushing
no
an open door here, Joanna,
Yeah.
because I've had very much the same conversation with Carol myself, and I think that she could quite easily say exactly what you're saying, because those are the very concerns that she expressed. That's not right? That's right, Carol, isn't it?
It is. It's not quite accurate though, Joe, to say that the quality team is not undertaking anything. That what they're doing, they're not physically visiting, but they are having structured telephone interviews with each and every registered manager, and that's the quality team is an integrated team from social care and the CCG, and they're going in. We've been delivering a lot of training. Again, facilitated by the experts in the CCG around infection control, etc. We're pushing through the SAB, as you know, the visiting tool, and I can confirm that my social workers are going into care homes. This is a relatively recent, but for the last 2 weeks they absolutely have, and that is why I've been pushing at national level for government to issue guidance about visitors, because it is vital. But I do think, Joe, we are going to see some safeguarding referrals as a result, and I don't think from only care homes actually. I also know that people have not made referrals into social care for mum and dad or husband, and we know that what we're seeing now coming through our front door are people who are in acute levels of need because they put off approaching us, and carers literally completely.
I know you'll keep us updated on that, Carol, won't you?
I will do.
Yeah, good. Richard, last one.
Yes, I just want to thank you very much indeed, Carol, for a superb presentation. I just wish all the idiot detractors online who write all the stupid letters and comments in would actually learn and read and understand what you and your team and the council are doing. And as regards to homeless, I did in a former life, I was a personnel manager at one of the big London hotels, and we had the same sort of attitude that there was always a reason why someone is homeless, and we get round that. We used to help them, we used to feed them, and say, look, come on, if you clean up and have we'll give you a job, and a lot of people responded to that. But my question is, there's always going to be some people who just can't cope on their own. And so what happens to them longer term?
Okay,
Do they just
so,
go back to being homeless or what?
no, so the government task force around homelessness is being crystal clear, and government is currently considering our and every other council's bid, a council with housing responsibilities, that is, because not county councils don't have housing responsibilities. So basically what it is saying is it expects, and we've moved from 81 people down to 59, so some people have gone back to whence they came. And that was basically sofa surfing, where they've been staying with family, etc. But government has been crystal clear that it expects nobody to return to the street, that actually we need to have move-on plans for each and every person. And to that effect, government announced £433 million. It's a huge amount of money, but when you divide it by the need, it's not a lot. But you know, we all know just how much of the public purse is going on to meeting the pandemic and the crisis. So £433 million has been announced for additional funding to support councils to continue to support these individuals. The expectation is that that will be done very much with health, because actually, you know, some of those people, as I've said, do have those mental health and substance misuse type issues. So it's seen not just as a, you need to get the housing right, as Councillor Hollis is referring, it's about getting those other elements right, so that, you know, as well as having the bricks and mortar, so to speak, you get the therapeutic input that you might need in order then to be able to turn your life around, not just, sorry, not, I don't mean just, but to not have to be surviving on the streets. So our bid is around the future of the Barton site, and we will hopefully find out if we've been successful. We were hoping to find out today. I've not heard anything. So I'm hoping that no news is good news as opposed to bad news. But we
okay, you'll update us on that, Carol. So with that, we'll move now to the last item that we're going to squeeze in today, which is Joanna on Healthwatch.
Very brief.
Thanks, John.
As briefly as you can, Joanna, because we're
absolutely. You'll be glad to hear some of the points we've discussed already. So just briefly, at Healthwatch, we've been producing fortnightly intelligence reports, which we've been sending out to all the statutory sectors, just so that they know what the public are telling us at the time. We've discussed B12 injections. More recently, we've seen an increase in anxiety around people, particularly as people realise that COVID is not going to go away within 3 months. It's going to be here for some time. We're getting people contact us that are anxious about waits for treatments, particularly orthopaedics and ophthalmology. And also, we've had feedback from the voluntary sector, who are also worried about the future and sustainability of their own sectors. And voluntary sector agencies such as Carers Isle of Wight, Community Action, they've done a huge amount of work to support people in the local community, and they'll be doing further work to support people who are shielding. And so the voluntary sector is essential throughout the COVID and possibly the second wave, because those are the people on the front line day to day supporting people in the local community.
Joanna, I think as always, your Healthwatch report is crystal mark, and as you say, it's been echoed right through this meeting, and we'll continue. The matters that you raised will continue to be raised at other meetings. So, with about 4 minutes to go, could I ask if there's any questions? No, we're all happy to. If anybody has any more questions, then feed them through Paul. So that being the case, can we have I'll propose that we note Healthwatch's report and thank Joanna for presenting it to us in such a clear fashion. And Michael, you got your hand up to second that or to say something?
No, to second it, Chair.
Okay, George, what did you have your hand up for some reason to second it or to say something?
I was going to second it as well, but
All right, okay, that's all right. So Brian, do you yes or no? Do you vote for or against that proposal? Yeah, George, yes. Richard,
yes.
Yes. John, yes. Michael, yes. Me, yes.
Yes, yes.
Very good. Yeah. Thank you very much for a very full meeting. The work plan is pretty straightforward. It's a work in progress as always, and we can review that informally with any input from partners if they so wish to steer us on our work plan. Always gratefully received. So thank you very much. No members' questions. Bye bye.
Bye bye.
Bye bye.
Bye bye.
Thank you.
There we are. Yeah, that one.